This is going to be the first of many of the lectures on the cardiovascular unit for pharmacology, unit number 5. We're going to be focusing on medications to treat a failing heart, medications for hypertension, medications for chest pain or angina, and also the lipid-lowering drugs. I want to do a quick review of the cardiovascular system, just to refresh, perhaps, some of the basic principles, and that will make the drugs a lot easier to understand. So just a couple general physiology, pathology, and pharmacological terms that will help this whole unit make a little bit more sense for us. So the reason why we focus so much on the cardiovascular disease is because cardiovascular disease is still the #1 killer in the US by a long margin, and therefore there needs to be some discussion on some interventions potentially for this particular disorder. Traditionally, cardiovascular disease is treated with either surgery or drugs. There's mechanical devices that we'll talk about for some of the dysrhythmias, but for the most part, medications are going to be the biggest intervention for cardiovascular disease. So here's a picture of the heart. This is not a healthy heart. It's a grossly enlarged heart. And it's the reason why we know it's enlarged is because of that big kind of round shape. The heart sits, as you know, in the mediastinum, the left wall of the wall of the left ventricle. The anterior wall of the left ventricle kind of faces forward. The left ventricle is our big pumping chamber. The heart, of course, is there it is in the mediastinum. The heart, of course, is divided into two almost distinct portions. I guess if you were to just go to the bare bones basic function of the heart itself, the heart is a pump, right? It's a pump that pumps into two different circuits. The right side of the heart pumps into the lungs, so we'd say that the right side of the heart pumps into the pulmonary circuit. The left side of the heart pumps systemically, and so the left side of the heart pumps into the systemic circuit. The heart chambers, of course, are divided from top and bottom by valves, the atrioventricular valves, and then the wall of the ventricles are also divided by a septum. So there's 4 separate chambers with 2 distinct sides. And again, the overarching function of the heart is to pump blood. So the functionality of the heart, or the efficiency of the heart, is going to be determined by how strong it squeezes, how fast, and how rhythmic the pumping. All of those things, the contractility of the heart or the strength of the pump, the rate and the rhythm, are all important, because if there's any discrepancy in any of those factors, then that's going to ultimately have adverse and potentially fatal consequences on the individual. Of course, the function of the heart is dependent on the blood flowing in a unidirectional fashion, so meaning from the atria to the ventricles, and then from the ventricles out. And so the role of the heart valves, the AV valves on the right and the left side, or the tricuspid and the bicuspid, or the tricuspid and the mitral, however you feel most comfortable, those are the valves that ensure that blood that moves into the ventricles from the atria stays in the ventricles when the ventricles start to contract. So as I'm sure you know, when the ventricles begin to contract, that just even initial pressure is enough to force those AV valves shut. And when those AV valves shut, then we have a completely closed chamber with the semilunar valves being shut as well. And so the pressure in the heart is able to increase. And then when the pressure in the heart, of course, is greater than the pressure in the vessels that are exiting those chambers, right and left side respectively, then the semilunar valves are forced open. On the right, we call that right semilunar valve the pulmonary valve, and on the left, we call the semilunar valve the aortic valve. And so as the pressure in the ventricles exceeds the pressure in either the pulmonary trunk or the aorta, the blood is ejected, and then immediately those semilunar valves shut again. So the job of the valves are to keep the blood flowing in that unidirectional fashion. And so valvular disorders can impede that and have negative consequences and ultimately potentially fatal consequences on the individual as well. Another thing to keep in mind about the heart is, as we said, there's 4 chambers, and you can see on that picture you have the atria on the top and the ventricles on the bottom. And in this picture you see that sort of plane drawn, between the atria and the ventricle. And the reason why that plane is significant is because that's referred to as the fibrous. It doesn't look like that, of course, but at that location, that's considered the fibrous skeleton of the heart. And the fibrous skeleton of the heart is significant because all of the heart valves are embedded in that bit of fibrous tissue. And the other thing that's significant of that location is that because it's a different tissue type, right, the rest of the heart is made up of endothelium, of course, on the inside, but then cardiac muscle tissue, and electrical tissue. So the electrical tissue depolarizes, and then that causes the cardiac muscle tissue to contract in a rhythmic and regular fashion normally. That fibrous skeleton of the heart is significant because it's a point of disconnection, if you will, between the atria and the ventricles. It's a different tissue type. So your atria can't communicate with your ventricles through that fibrous skeleton. So the AV bundle, or the bundle of His, however you learned it, is kind of that little bit of electrical tissue that dives through the fibrous skeleton of the heart, just distal to the AV node, and then takes that electrical signal down into the bundle branches and ultimately into the Purkinje fibers. So that's another structural or an anatomical kind of issue that we have to sort of keep in mind, especially when we're looking at dysrhythmias and conduction abnormalities. So this is a picture of the depolarization in the heart. The electrical system of the heart, of course, initiates at the SA node, followed by the AV node. So the SA node depolarizes the fastest under normal conditions, somewhere around 75 beats per minute. The AV node is going to be slower, somewhere between 40 and 60 beats per minute. And then we're going to go through the AV bundle and down the bundle branches and into the Purkinje fibers, and they're going to be slower yet as well. But anything in the electrical conduction system has the potential to depolarize. We'll talk more about that in a minute. So this is electrical physiology. You've learned this before, right? This is action potentials. And so what this is showing us is kind of the action potential in cardiac tissue. And it's a little bit different than what we see in any other electrical tissue anywhere else, because there's an additional channel, right? When we think of action potentials, we think of a stimulation and we think of sodium influx causing, ultimately bringing somebody up, depolarizing to a point of threshold and then generating an action potential. And then once we get to the peak of the action potential, the sodium channels close and the potassium channels open, and there's a potassium efflux, and that's what brings us right back down again. It gives us that sort of characteristic spike. When you look at this picture, you see it's a little bit different. And the reason for this is the main reason for this is one of the reasons why the heart is so unique, or the electrical system of the heart, I should say, is so unique. And it's that we have an additional channel, and that additional channel is a calcium channel. And so what's happening here is the sodium influx, right? And in addition to that, we also we don't need to be externally stimulated, if you will, right? There's these channels, these sodium and calcium channels are kind of referred to as sort of leaky channels, in that they slowly leak sodium primarily. And as sodium slowly leaks in, that signal is going to, or the current, I guess, across the membrane is going to slowly drift up towards threshold. And then the calcium channels will open as well. The sodium channels will close. And normally when the sodium channels close, you go right back down. But in this case, since the calcium channels are slower to open and slower to close, we see that kind of plateau. And then the calcium channel closes and then potassium channels open. So we will see this picture again when we talk about our drugs that affect the rhythm or the rate of the heart, which are used for situations where there's some sort of dysrhythmia or arrhythmic agents. These are called anti-arrhythmic agents. And there's a couple different classes, which we'll come back to, but you can see them each on this slide. On the far left, you see the sodium channel blockers. Those are drugs like quinidine. Also, another drug that's a sodium channel blocker is lidocaine, which is used a lot. Then you have the calcium channel blockers, the beta blockers, which we know about now, right? Beta blockers are what we talked about in our last unit, blocking particularly in this case the beta 1 receptors of the heart, slowing the heart rate down. and then potassium channel blockers. So we'll come back to these drugs in a little bit and see this picture again and explain it, but this is just showing us that there's a little bit of difference in the way the cells in the electrical cells in the heart depolarize. And there's more to it than that, of course, you probably remember from physiology, but that's enough for our purposes in this class. So when we think of the action potential and how it pertains to the heart, what we think about kind of is the ability to look at EKGs or ECGs and extrapolate from an ECG what's going on in the heart electrically. And so what you see in this picture is you see in this picture happens to be looking just at a ventricle, so you see the absence of the P waves, but you can kind of see what's happening electrically down at the bottom in the ECG. And then you can see in this top part of the picture the action potential in the ventricular muscle itself. So we're looking at like electrical information on the bottom and then muscle tissue on the top. For our purposes, I'm not going to focus on the phases of depolarization and the phases of the action potential. It's kind of outside of the scope of what we need to talk about in this introductory course, but you may recall some of it from physiology. All right, so when the heart has the ability to spontaneously depolarize or self-stimulate, if you will, that is referred to in the cardiovascular system as automaticity. So that's the capacity for repetitive self-stimulation, which is a very unique, right? And it makes the heart, it's what ensures that the heart rate is both rhythmic and regular. So the conduction system of the heart is responsible for this, the electrical conduction system of the heart, and those sort of useful and unique channels that leak in sodium. We have the electrical system of the heart, again, is composed of the SA node or the pacemaker, the AV node, the bundle of His, or you may have learned of this as the AV bundle, the Purkinje system. And as we go from the SA node all the way through the Purkinje system, any of those cells have the capacity to spontaneously depolarize. They have the capacity for automaticity. They're just going to do it at different rates. The SA node is considered the pacemaker because it does it the fastest, followed by the AV node, followed by the bundle, followed by the Purkinje fibers, which are the slowest. And again, the mechanism was what we were just kind of talking about, the slow influx of sodium and then calcium, and then the kind of the plateau because of the calcium channels, and then the efflux of the potassium. So that kind of slow drifting in of the sodium and then the calcium, so we kind of refer to that as a slow like drift up towards threshold and then generate an action potential. And then at the end of the repolarization phase, we start slowly drifting up and an action potential. So that slow drift to fire is kind of what we refer to as the pacemaker current. And again, that's what makes the heart very unique in its capacity to spontaneously self-depolarize. So again, depolarization, we just mentioned this. Excuse the phone, I don't know how to turn it off. The cell membrane becomes more permeable to sodium. Sodium rushes in, followed by calcium. Calcium rushes in, and then the potassium ions move out. So that's the way that cells depolarize, right? In every other electrical cell, it's sodium and potassium, but here we have this extra benefit of the calcium. All right, so I don't think we need to spend a whole lot of time talking about this. So there's these, if you remember from physiology, there's the slow channels and the fast channels. The slow channels are the ones that respond to or have this calcium influx, right? So some of the cells in the conduction system depolarize specifically as a result of calcium entry, right? Those calcium respondent cells are found specifically in the SA node and the AV node, and therefore the electrical impulse in these locations it takes a little bit longer for the electrical impulse to be conducted, and importantly, the recovery takes a little bit longer. So the SA node and the AV node are dependent on this kind of slow current, and this slow current, again, is what I was talking about. It's that slow drift up to fire, drift up and then fire, and then drift up and then fire. And that's different from what you learned about in electrophysiology, where you have influx of sodium and this quick spike once you reach threshold and then come down. If you remember from the pictures we just saw, it was more of a subtle, kind of an incline.